During traditional ventilation, inspiratory tidal volume must overcome airway impedance and elastic forces of the restricted lung. As compliance decreases, the inspiratory limb of the pressure volume curve shifts to the right, where more pressure is required to deliver a set tidal volume. However, the expiratory limb remains unaffected by the prevailing pressure-volume relationship and extends throughout all phases of injury. For ventilation, APRV utilizes the more favorable pressure-volume relationship of the expiratory limb. Recruitment occurs after pressure exceeds closing forces in the lung. Once alveolar expansion develops, the time above the critical opening pressure is vital for sustained recruitment. With APRV, there is less dead space ventilation. The patient can therefore be managed with lower tidal volumes and still maintain equivalent CO2 levels. Human lungs have parallel and serial air passages, allowing gases to redistribute from areas with short to long time constants. This may be critical for achieving recruitment in non-homogeneous lung disease. Intrapulmonary gas redistribution occurs as inflation pressure is maintained and extends to equal the longest time constant. As gas volume redistributes, time constants evolve towards uniform distribution, improving alveolar recruitment. In addition, pulmonary interdependence perpetuates further alveolar recruitment. During progressive alveolar recruitment, adjacent collapsed alveoli are stabilized and recruited as radial stretch forces alter opening pressures. Ideally, mechanical ventilation should potentiate alveolar recruitment, optimize interpulmonary gas distribution, and narrow time constant discrepancies. Therefore, inflation pressure should be interrupted minimally in frequency and duration. APRV allows continuous airway pressure, providing maximal recruitment as critical opening pressures are exceeded and maintained. The use of APRV in optimizing mean airway pressure and lung volume also provides greater surface area for gas exchange. It is also important to note that allowing for adequate CPAP duration and limiting release time permits only partial emptying of the lung. This limits lung volume loss. Pressure release time should never allow complete gas exhalation to minimize the risk of derecruitment. APRV is associated with less dead space ventilation. The end effect is greater gas distribution in all lung regions, improved oxygenation, and the reduced need for high-minute ventilation.
Comprehensive respiratory care is not complete if mechanical ventilation remains the sole focus. Ventilator management should encompass all factors adversely affecting the lungs. Most mechanical ventilators monitor airway pressures. However, transalveolar pressures ultimately determine volume change. Although difficult to monitor clinically, transpulmonary pressure should not be excluded from management principles. Prone positioning, diaphragmatic tone, and spontaneous breaths all modify pleural pressure. By lowering pleural pressure, transalveolar pressure gradients increase in dependent lung regions, improving ventilation without additional airway pressure. During intermittent prone positioning, transalveolar pressure increases improve gas exchange as dependent lung regions are recruited. Oxygen and ventilator requirements are therefore lowered. Spontaneous breathing improves transalveolar pressure gradients, augmenting dependent lung ventilation. Clinical and experimental reports have shown spontaneous breathing improves arterial oxygenation, cardiac output, and oxygen delivery without affecting oxygen consumption of minute ventilation. Spontaneous breathing provides respiratory muscle conditioning, maintains muscle mass, and promotes weaning.
Minimizing neuromuscular blockade during respiratory failure will reduce the incidence of prolonged paralysis and save the cost of administering and monitoring neuromuscular blocking agents. Reducing ventilator days lessens the risk of nosocomial infection, leading to shorter stays in the ICU.
APRV has nearly eliminated the need for the use of paralytics in patients with advanced respiratory failure. Airway pressure release ventilation provides the patient-ventilator harmony that will change the direction of ventilatory management.